Thank you. And if you see colleagues that aren't in this room, let them know we're down this hall. I didn't even know until about an hour ago that there were education sessions.
It's been fun today.
Yeah. So I'm Dustin Telford, as I was introduced. I've worked in HTM for over 30 years. I joined ECRI about 2 years ago in our device safety consulting group, and we're going to be talking, as was mentioned, about digital darkness. We'll get into what that is. Jeremy, I'm joined by Jeremy. He works he's a manager in the device evaluation group. Yep. We both work under device safety. Jeremy's going to bring the perspective of the PE in the room, the professional engineer, the clinical engineer, more than I will. So think of me as your biomed cybersecurity expert. Jeremy's going to talk from the cybersecurity standpoint as well, but about more of the systems and the investigations that may need to take place to get to better results. In the next hour, we're going to walk through what happens when a major system or all of your systems go out due to an event. Now, it is about digital darkness. We're going to talk about what that can mean. But the core of it is when those systems, like all your bedside monitoring, goes out, or for example, when there's a disaster in your local area, like years ago, Joplin was hit by the hurricane, or a tornado, I should say. They're a little inland for a hurricane. And if you recall, some of you may have been around, there were several articles about how biomed responded to the needs of the hospital when the hospital was physically destroyed. I'm gonna talk to you about ECRI. Some of you may not be familiar with ECRI. ECRI is a nonprofit organization centered around patient safety. We started really with the HTM and medical device industry from our founder, who essentially saw a need for a variety of reasons, including he made some mistakes early on in his career before founding ECRI about medical device safety, right? And what it takes for a clinician to be able to effectively use a device or safely use a device, and the engineering principles behind it. And then it evolved into an audience more like me. When I started in the field, I used ECRI because ECRI was my resource. People like Jeremy were the people that had evaluated the equipment. If you haven't heard this tagline, if you will, it wasn't really an official tagline, but ECRI was and still is kind of consumer reports for medical equipment, among other things, the fair evaluation process. So I'm gonna advance my own slides. So when a device fails or an incident occurs, Jeremy and his team will often get involved in the accident investigation, as we call it. But from a high level, they'll get involved in systems level thinking too about what also needed to happen as a result, possibly to prevent this from ever happening again. Our journey ahead is we're going to talk about how HCM professionals can proactively establish what to do before it happens, right? So we're going to define digital darkness, what it is, what it looks like. We're going to talk about the what. We're going to talk about 6 different kind of categories of events that can occur that will result in a digital darkness event, and the how, right? How to approach these things before they happen, as they're happening. We're not going to spend as much time about as they're happening because we're hoping to prepare you. And we're also going to talk about the post-incident investigation, what you do to recover and what you do to make sure it works better the next time possibly that it happens. One bit that we don't have in this slide, and slide deck really, and I'm going to bring this up, is all of you in this room and those people that you know at other organizations, talk to them about what they have experienced in their institution. When you think about digital darkness, it doesn't have to be an attack from an outside, or it doesn't have to be just a cyber security threat. you may find that another organization has handled something or made some mistakes that will hopefully help prepare you better and your team better if you learn from their mistakes, and maybe even work with them on developing better plans. Oh yeah, I keep thinking I got the clicker. Anyway, so the why. Said we're going to cover these 4 points. The why of digital darkness. What happens when every screen in your organization goes black? Panic. Okay. That is a response. We're going to talk, and that's a normal response. My experience has been that you can do a lot of preparation, but it usually happens at 2 a.m. in the morning, or when on the weekend when maybe you don't have full staff coverage, or it happens when the one guy that knows the systems really, really well is out. If you'll click the next slide. So digital darkness is the sudden collapse of a major system or all systems that support your basically your internet connectivity or your intranet connectivity or both. We've heard a lot recently about the term digital darkness in the media. Last month, Iran went through what all the media was talking about was digital darkness. This was prepared more to talk about one of our top 10 hazards that we identified last fall for healthcare, right? MD Expo said, sounds good. But when your EHR crashes, when your monitors go dark, your badge readers freeze, or even your pumps lose network connectivity or that sync. So what do? Are you prepared for what comes next? Next slide. I mentioned that we're going to talk about the what those 6 categories really look like. And these are categories at a very high level about what can cause a digital darkness event. So the obvious is probably cyber attacks, right? An external attack or possibly a bad actor within your organization, a disgruntled employee or somebody that didn't do their job well enough to secure devices, or a network. Vendor outages, I'm going to kind of go left to right and down. Vendor outages might be something that you're dependent on outside, a cloud-based system or a system that's hosted by another organization, or for that matter, how many of you have had, like your monitoring vendor, come to you and say, we just identified an issue that is going to occur or already has occurred because, and not Y2K, but we've identified a glitch, right? Because of some transition in date. If you've seen those kind of things, that's a vendor outage, right? Something that the vendor has some sort of responsibility for, but didn't identify or didn't help mitigate that risk to your organization, but now it impacts your organization. Your monitors go dark, you're not charting correctly or whatever. Natural disasters.
Yeah, so looking at the physical aspects, natural disasters, keep in mind that they can create cascading failures that go way beyond just power loss. Even though power loss is a big thing, there could be lots of other things to deal with. You could have structural damage, you could have water intrusion into the building, your HVAC could go down, or even just trouble accessing certain parts of your facility. So these are things to consider. Internal system failures, so things like your network going down or generators failing under load. These are engineering problems that create lots of scenarios that can just cause your devices to have problems, sometimes insidious. It may look like they're operating correctly, but there's really some problem underneath.
So, and here's where there's a critical point to consider. Look at that, the warning bar at the bottom. Oh,
Sorry.
No, it's okay.
There we go.
Look at the warning bar. Actually, it's up here. look at the warning. Combinations of events can occur at the same time. So Jeremy, for example, mentioned what happens if your generator fails or your N+1 generator fails. In that event, it's probably going to take out power, at least some of your power, to critical systems such as your network. Or it's going to take out enough power that now you're on backup battery and you're on time, right? You now have time limits. It doesn't just knock out power, for example. It takes down your communication simultaneously. It takes down your EHR and your ability to do work as you normally would have. A good example is this. Even if you have an internal system failure of your communication systems, if you're on VoIP phones across your organization, you may now have to switch or consider switching to something else, right? If your biomed team usually operates off of being able to call somebody on an ASCOM phone or another phone, you might need their cell phone number. They may need to grab their own cell phone if they have a cell phone, assuming most of them do, and start that communication that you would normally do through the hospital system. Now, if it's an external failure, mobile device systems fail, and I've seen this in rural healthcare systems, it presents a whole nother problem, right? You can't use your cell phone. But the point is, combination events can happen, and there's this critical point to consider of digital darkness preparedness should begin before you actually have the event. You should think about what would happen if this happens. And again, those 6 categories, the likelihood of these events occurring. So do a little raise of the hands. Raise your hand if your organization has a documented downtime procedure for HTM, just policy-wise. Okay. Have you actually tested it? Raise your hand or keep it up if you have actually tested it. It's not just on paper. Well, Dallas, it's a good point, and we're going to get to that. Is I'm asking, have you done at least a tabletop exercise, or something happened, right? And now you were able to test it, right? See how it actually works. And that you know your devices, and how many of you know which devices are supposed to be on generator? Okay, and I'm not talking, we'll talk a little bit about the red outlets, but I'm talking about the stuff in the closets too. Okay, that's some of the gaps we're going to try and address as far as identifying what you may want to think about to be prepared. Jeremy was right. He was like, "You're doing a lot of the talking," and I So the how. This is really the meat and potatoes of the presentation, being prepared. We will address some questions that you may have at the end, but how do you get prepared? You need to build a playbook. You need to think about these scenarios that pose a risk to your organization. If you're silly like me and I said Joplin and it was a hurricane, you can eliminate probably the risk of a hurricane in Joplin, but tornadoes hit that area regularly. So you may want to think about what natural disasters can occur. You may need to think about those other 6 categories, and you should think about all those 6 categories. An eternal bad actor, so to speak, a disgruntled employee, or maybe somebody that makes a mistake in securing your network or your devices, can happen just as easily, probably more easily than the risk of an external terrorist kind of threat. But the point is, we're going to talk about the how. How do you get prepared, and what do you do during the event and post-event? Next slide, please.
So when everything goes dark, one of your primary questions should be, and this is a natural thing, is what devices or systems do we need to keep running to keep our patients alive, right? That's probably question number 1. So we can think about that concept as the minimum viable hospital, right? And so on the left here is toward the bottom we have an example of a priority list, right? So your life support systems, your monitoring systems, and the like, things that you just need to keep running. And you need to consider, how do each of these systems or devices, what are the failure modes, right? So things that are on battery backup, you have limited runtime. Things that are on generator, you have to make sure that they're plugged in correctly. Other devices that will keep running, they may switch to a standalone mode so they can keep you moving, but they might not, depending on how they were configured when they were first installed. So all these things are things that you need to consider. So then on the right is just questions you need to think about, and you need to run an audit, right? So Dustin already alluded to the fact that there are things you want to think about ahead of time, not when the event occurs. And so think about what systems are on battery or not. Are they properly plugged into generator-backed outlets? Do you have documentation of what's supposed to happen when things go down and when you can't run? And who's responsible for recovery? Is it HTM? Is it IT? Is it facilities? For each of the systems that are critical. So, and this is one of the things you're going to hear us, it's already been said, but we're going to keep repeating it. You need to practice ahead of time. So it's not just a one-time set up your procedures. It's you set them up and then periodically you come back and you do an exercise or do something to verify that your plan is still appropriate.
So these four, you can do next slide, I guess.
There we go.
These four items are the kind of the foundations of preparing that checklist. You got to know what's in your inventory, right? Jeremy, for example, and I both mentioned what's on red outlets. And to connect the dots, it's not necessarily what is connected to a red outlet. Hopefully it's your ventilators are connected to a red outlet in the rooms, but that's a responsibility one would hope at least that the nurses and the RTs would take seriously. It's about what's connected in the closet. If Jesse, and I'm going to pick on Jesse because I know him, if Jesse goes into an IT closet and recognizes that, and hopefully is kind of just doing a visual environment inspection, recognizes that some critical switches are not on red outlets or not on the emergency feed or line or battery, that might be a cue to prepare in advance. But your asset inventory includes all those things, right? And whether or not it's managed by IT or HTM or facilities, think about it this way. Don't leave it up to an assumption. I've worked in organizations where IT has felt like those device networks that are medical device networks only are solely managed by Biomet, and Biomet's thought, oh, they manage all the switches in the closet. Do a power supply audit, right? Do these, and this should be a facilities responsibility or collaboration, but make sure that those red outlets, right, those emergency feeds are actually what they say they are. Make sure that they are, because you'll find, and I have found this enough in my career, you'll find occasionally there's something that's mislabeled and it winds up being very obvious when the network goes down or the room goes down or whatever. Now, this is a little controversial sometimes, but make sure you have reliable batteries. I know there's been a lot of discussion in the industry about batteries being a very big expense, but I can tell you personally that one thing that comes up usually in a downtime event of any type, to me, has been how long are our ventilators going to work? It's important to know with a high confidence level, at least, that if it's been maintained properly and you have the right batteries in there, whatever the criteria are for your organization, that you can tell an institution it should run this long before we have to make another judgment call. right? We have to put it on UPS. We have to find another way to treat the patient because those downtimes can occur longer than 45 minutes, and they will. Now that's more of a power issue, but the same thing applies again in the back closet, right? Or it applies to the central monitoring station that has the UPS on it in your at your nurse's station. And then we're going to talk about this as well. It's those emergency kits. Now, the emergency kits, if you're reading the slide and as I talk through this, the emergency kits are, I think, a responsibility that IT, facilities, and HTM should support the clinicians on in some way, fashion, or form. It's probably their responsibility. Some of these are, do they have flashlights, right? Some of these are, do they have manual blood pressure cuffs or battery operated pulse oximeters? But we all probably have had this experience where one floor does a pretty darn good job of keeping those things up to date, and another floor necessarily doesn't. That's why I say, you know, continue to support those departments in developing and executing on that plan, because before the event happens, if they have D batteries or C batteries for their flashlights on hand and they're fresh, probably a better time to support them than in the emergency when you are likely to be pulled on something more critical, right? Something that you may not have anticipated or that you may need to be managing a little bit more than getting around the rooms and doing vital signs checks, et cetera, or for the supporting the nursing staff.
So going to reiterate, documentation is extremely important. And so in this context, though, we need to think about or keep in mind in a digital darkness event, if it's only digital, it doesn't exist in a digital darkness event, right? If it's on a server or a laptop somewhere, folks are probably not going to be able to get to it. So that's something to keep in mind. You need to have procedures printed on paper, probably laminated is a good idea, and stored somewhere that everyone knows where it is and can access it. So for equipment like beds, vents, whatever, things that have manual overrides, your staff need to be able to get to those procedures and know how to run them. Cold storage, that's another thing to think about. You need to have dry ice plans in place because you don't want to lose specimens or reagents that you can't replace, right? So you need to maintain those. Communication plans need to be coordinated with facilities and other groups. So you need to know, for example, generators have a limited capacity, right? So if everyone tries to use that capability all at once, you could overload your generator. So you need to have a plan for all of that. Don't forget about handling hazardous materials. So your fume hoods are down, you could have exposure risks that need to be dealt with. So think about all these areas ahead of time.
So I'm going to zoom out a little bit from the more HTM specific examples, including that support example, support your clinical users, and talk about the organization, right? If you have not been in the incident command center, one thing I would advise you to do in Dallas, hopefully you take somebody that's junior and you go through at least what they would experience if you are not there in the incident command center. I don't know who your structure is, maybe you're not in it anyway, but if you're not there, or the person that practices and knows how that center works is not there, what's your backup plan, right?
Actually, anytime there's something going on, during our huddles, do a debrief inside baseball for the entire team. But we've had situations, snow events, where people have to spend the night on site, and we report to those individual technician level reporting to the incident command center. So they're getting that familiarity, and we rotate. So
Okay. Good. So I didn't pay him for this, but this is a good example of make sure that everybody knows, not just on the paper, the laminated copies or whatever, the paper book that we've suggested, or books that are the resource guide for the technician that doesn't really know the ventilators, but needs to be able to answer a question to a concerned nursing staff member that says, how long are these going to last? But also give them opportunities to understand in context what they may need to do, because in the case of any event, a digital darkness event can occur when Dallas is out of town. Okay, it can be that time when the primary point person is not available, and other people are going to need to take on those roles. Give them the playbook. Which now kind of leads me into this, the roles and responsibilities. If you're not familiar with conducting a RACI, hopefully most of you are with IT. Who's responsible, who's accountable, who's communicated to or communicated with, I should say, and who's informed about a down system. Define this for your normal business operations, but define it what happens in those extraordinary situations where, say, the network goes down, right? Who is responsible for that particular server or that closet or all networks means a lot. I unfortunately have seen it where we hadn't established the RACI clearly on patient monitoring, and I had to, as the leader of the department, intervene in a way that was a little uncomfortable with IT and say, you know, all these other systems that are going down, they're all connected to my patient monitoring system as well. I know your focus is on these things, but if you establish this in advance, you have clear instructions for who is responsible for doing the work, who's accountable, and who you're telling, right? Essentially, are you informing the CNO about something that will certainly rise to the top before they have the question, or before they start asking the question? Do you want to, or am I on these? I'm on the incident response and recovery procedures.
I mean, I can talk, but.
Oh, okay.
Yeah.
So on the incident response portion of this, don't think about how necessarily you are responding to it or in isolation. You got to think about how you're going to turn the lights back on, right? How you're going to bring systems up and in what sequence those systems need to come up. With a more interconnected work environment or healthcare environment, there may be certain systems that need to come up first before you can turn on that MRI and have all the functionality that you once had, right? Or that you need to restore. But it also may be that you're going to restore first, not the MRI, but you're going to restore first some other more critical system like the 32-bed ICU. That 32 beds, although most of the monitoring systems out there will operate in a standalone environment, nursing is staffed with the assumption, at least in most cases, that there's somebody else conducting some sort of oversight, either in a war room or at the nurse's station or whatever, of all those bedsides and alerting nurses that there's a critical need. And the ICU is not necessarily the best example, only in regards to usually that's a like 2-to-1 staffing, but in a step down unit, it's going to be a lot less. And then testing and any updates. Simulate these type of things. Really, I wouldn't go and unplug your network switches, but talk about what would happen in these cases and see what your plan would be. Simulate it and validate it, right? If you actually have an event, just like our counterparts in facilities will do, if you have an event, you can check that box off and say, I had a similar event that tested my plan. Count that as your test. You don't have to have the test a month later on the tabletop exercise sometimes. Conserve your time.
Also important, before any of this happens, like you're saying, if you're in charge of the GE monitoring, do you have your own monitoring topology to know where all the points of contact are, so that you can start isolating things, getting stuff back on.
Yeah, the fundamentals of where everything is in your environment. And in an hour, and thanks, that's a very good point to bring up. In an hour, we could only bring up certain points that we wanted to kind of hammer home. But one thing on the updates that I will mention, if you update a system, and this actually probably ties into this, if you update a system, say the topology on your GE monitoring system, to use Dallas's example, make sure that those backup records, those things that are in place, if you don't have access to the digital copies, right, or the digital solutions, make sure that you update those records immediately. You don't know when an event's going to happen, so you may as well have an updated material. Don't wait for your vendors to come back months later and tell you that here's your new network map. Oh. Is this, oh, sorry, this is,
You start and then
this is me. Most digital darkness events don't occur in isolation from one or another. They don't occur without some sort of warning, right? If by a raise of hands who here dealt with WannaCry a couple of years ago. Okay. In the US, we started to hear, at least some of us started to hear, that there were effects in the UK of WannaCry a couple of hours before it started impacting organizations in healthcare and other settings. So sometimes those events are somewhat predictable. Natural disasters, such as a hurricane, the predictions are usually pretty good, where it's going to land, about what category. We don't necessarily always know what the effects to the particular buildings or infrastructure will be, but you can prepare for that. You can have people potentially staged at your facility if you feel that, and likely in biomed, you're going to have people on the ground, right? But
yeah, just to really, there's thinking about your devices, there's things that you can know ahead of time that will allow you to handle an event much more smoothly. So knowing your battery run times, the generator loads, knowing where the manual procedures are. So these are all knowable now, today, and so it's better to just be prepared. That will make it much easier to handle those situations. If you're not prepared, when the event happens, you're going to have to be, you and your teams and colleagues are going to be having to make a lot of decisions under stress, probably with incomplete information, and opening yourselves to a lot of risk of having adverse events happening in that situation.
So the truth about preparation is plans are just that. They're your map. Preparation is really muscle memory, right? You prepare for these things before they happen. You practice them. You put them into practice. You execute it so that when it happens, people aren't pulling their hair out. Those of you that still have hair, I envy you. And keep your plans updated, right? Continuously monitor, is this plan still effective? To give you a brief example, I led a department that we were in one shop. Fortunately, we got at a second shop due to natural growth and space, but we rewrote our policy about what would happen in certain events and where people would collect, right? Where we would then divvy out what work needed to be done if communications were lost. We did that very quickly because we identified now we have two spaces that we need to address. And I didn't want my whole workforce to go to one shop that the building could be out of commission, right? Or I didn't want them all congregating and traveling a long, long distance between the two shops for no good reason, right? So we had to come up with how do we manage essentially two departments, right? Across the street, but still a distance away.
All right, so we've talked about how to prepare before an event happens and some things about during, but now let's talk about recovery, which might sound like the easy part, but it's not. So we're going to cover some common pitfalls of the recovery process.
So some of those are assuming that your data backups are clean. We've mentioned update your plans. Make sure your data backups are current, right? If you're planning on restoring a system, or you might have to restore a system to its last backup, make sure that it's clean. Oftentimes organizations will fail on this point alone, and then it spends more technician time and engineering time to try and get it back to the state that it should have been in, the alarm settings, et cetera, say on a patient monitoring system.
And then thinking about your devices, a similar mistake would be just assuming they're all ready to go, power them back on, and let's run. After a power event, or if there's an extended outage or extreme heat or water intrusion, some devices, you might need to run some functional testing and verification to make sure that they are operating appropriately before you just put them back online.
And the last that we're going to mention, at least here, is the lack of training. We've said this a couple of times. Practice, practice, practice. Build that muscle memory. Don't just write it down on paper. It's good backup when people lose their mind. But the importance is that if people know how to handle a situation that doesn't come up, hopefully very often, at least they have a starting point, and they have a certain level of confidence beyond being the inexperienced person that hasn't experienced this problem, doesn't maybe know what decisions to make next, and needs to operate in many cases very independently, and then report back up maybe what they're doing. So how you recover depends on what type of event. Ransomware, the backup portion may come in handy. And I didn't mention this, but on backups, make sure that you're not reinfecting your system, right? If you have a backup that's too current, it may have the risk. Test if you have the ability, and some systems do, test before you run through a full deployment. Sample it in some smaller area where it won't make as much of an impact if you have to go back to the backup before, or several backups before. So validate your backups. A phased system restoration, I've mentioned this, but sometimes certain systems need to come up before another system comes up. The obvious would be power needs to come up before devices that are not on emergency power, right? Or that are on their last legs as far as battery operation. But the less obvious may be that in the MRI example that I alluded to, you may need to restore certain workstations before you bring or you ramp up, say, the MR that's been down long enough to be a little sketchy to fully start seeing patients. Data integrity, make sure that your data that you generated during this downtime can go back in. The data that's essential can go back into your systems. I see you kind of laughing, but is there?
No, looking at the AI.
Oh, yes. Yeah, this is thanks to the other presenters. He did this in Copilot. He's got some good ones. Scott Looney. And then if you have a restoration point, it doesn't always have the same credentials that people generally had to log into before. It may have no credentials. Take the time to make sure that you're setting it back to Dr. So-and-so came on board last month, for example. Now Dr. So-and-so can't access this system. You will get a call back. It may not be that same day, but the next day, and they'll say, well, something's still wrong with the system, right? Thank you.
So I got ahead of myself a little bit, but for things like recovering from a natural disaster, again, not all equipment may be ready to just put back online. So you want to assess damage both to the facility. There could be structural damage or other issues that compromise the performance of your devices. but then also looking at the systems and networks and the power supply themselves. You want to inspect and test your devices, both visually and any other performance testings that you think you need to do. And then so that transition from everything being down to coming back to normal, just need to do it carefully, but that needs to be considered just as critically as going into the digital darkness event.
So for an internal failure, IT is generally going to be the group that restores the network infrastructure generally. I was talking to you about how sometimes those, again, racy. Remember that model. If you're not using it, we can talk, and I can give you some examples, or some other organizations can. But you should have somebody in the column of who's responsible for doing what. Your HTM role is probably I'm trying to see my notes. A phased reconnection by clinical priority. It may not be the same priorities that IT has. Again, work with IT facilities and HTM clinical engineering. It can. It certainly should in their business continuity, but I'm talking about in practice what is executed on more of the task list, the procedures of what comes up next. But absolutely. So you should have a business continuity plan, and that sense sets the stage for the end results, right? What needs to come up first. So absolutely, yes. So if you don't have a business continuity plan developed organization-wide, you need to understand what services are the most important to your organization. If you're a primary care trauma hospital, everybody's going to be saying, why is our MRI or our CT not a priority? You need to understand which systems are the priority so that you can say, this is what we established before, we're sticking with the plan, or we have to adjust because your MRI is not a commission or whatever. But thank you. Thanks for bringing that up. So next slide, please, Silver.
So no matter what is causing the event, here are 5 universal principles for recovery. So one, as we've said, staff preparedness. So have a plan beforehand, practice that plan. Staff need to be comfortable with what needs to happen when you're going to manual procedures when the event happens, and then also what to do when they're coming off manual procedures and returning online. Prioritization, we've discussed this. So knowing what's critical, what needs to come back online first. In general, right, you want to restore your clinical systems before the administrative stuff, right? You want to get your monitors back before Outlook. In general, right? I'm sure there's some caveat in there where there's some critical system that needs an administrative component. Yeah, so there's a general principle, right? But you need to think about the details for your facility.
It's interesting you brought that up, but vendor collaboration, make sure you have your SLAs established with your vendors. You have a backup vendor in some cases for certain critical solutions or systems. But if you're dependent on a vendor, which many of us are, to provide some sort of cloud hosted service or whatever, or offsite service, make sure you are communicating with them during this event and teeing them up so that they are either working on a solution from their end or prepared to start bringing certain systems back online. You may be impacted initially, but on their end, they may need to reconnect. The next thing is your compliance. Work with legal and compliance staff to make sure that you have this oversight to say, what are the risks to the institution if we decided to say, bring up patient monitoring versus the MRI, right? Are we that concerned about our reputational risk and our compliance risk? What do we need to do? And document. what actions you took in an event. The reason why I say this is just like any good biomed technician or whatever would at least mentally document what they did to troubleshoot the process. At some point, hopefully, like Dallas has brought up, you're doing some sort of after action, right? It will be brought up at some point. We didn't anticipate this system going down in this way, or that it wasn't going to be an issue or whatever, and then you can adjust your plans, right? Hopefully, again, prepare before, but assess after. And I've already mentioned kind of reputation management, but the key here is follow your organizational guidelines. Don't talk to the media about, usually organizations will say, direct that to marketing or the media services folks or the CEO of the hospital about what happened and how you restored it. But think about this. Your role in reputation management is not only following that, but also following your internal policies to communicate effectively to those people what you did with a certain confidence level to bring it up, to restore systems, et cetera. That's the key really on reputation for HTM professionals.
Sorry, I jumped too far.
So here's some things that you can do Monday morning, or if you're so inclined, tomorrow morning, if you're going back to work tomorrow. You need to audit your critical power sources, right? This is a big failure point, natural disasters, especially, or some sort of generator issues or whatever.
Yeah, one thing on that, and this is just from experience, we have a CT scanner, and majority of the requirements for CT scanners require injectors. How many of your injectors are on backup power? Transitional. We get like wheel 16 and CTs on flywheel, so we don't use power, so we actually get flywheel outlets installed injectors so they won't lose power. If you're in the middle of a scan, you start in the injection, the power goes out, you're not injecting the patient. So, something.
And that's a really good point. It kind of led me to this. There are sometimes manual overrides or manual solutions for injectors in, say, CT, right? There is not, that I'm aware of, a very good solution if you want contrast in a cath lab, right? If they need contrast in a cath lab. Cath labs usually will have additional layers of protection for power, right? Some UPS for the whole system. But when you were saying the CT, one thing to consider is when you're auditing your critical device power sources, I'm going to add here, make sure you know what is backed up on backup of power. It is often a solution to say back up the MRI coil, but that the closet, right, the chiller and those things can go down, right, and not be on battery backup because it's an expensive spend. And some organizations, most organizations that I've seen, will not spend that. So you've got to know, hey, you can't just flip on the MR in that example. But again, Monday morning, start auditing your critical device power. Think about this. What is critical, and what power requirements does it have to be fully up and running? Locate or start creating your downtime procedures. Build that RACI matrix. We've mentioned that a couple of times, but make sure that IT is involved. Make sure that facilities involved, and in some cases even materials management, right? There are others, but make sure that they and you all come to the table. You don't just build this on your own. Schedule tabletop exercises. And just as a reminder, if you have an actual event that can qualify as a tabletop exercise, consider taking that off your schedule, right? You can still have it, it's not a bad thing, but everybody has a limited amount of time in a healthcare organization. Take the facilities tact, I think. Most facilities organizations will say, well, we had an emergency power event, we tested under load, we don't need to do the monthly check. And integrate digital darkness planning into your disaster preparedness or your incident response preparedness plans. Make sure that that's part of the solutions. If IT's not, and they almost certainly should be, but if they're not at the table about thinking the medical devices are just as important, the organization needs to come together and understand that there are administrative systems that are important, like the EHR, but the medical devices and the medical device networks are equally important, at least.
I just want to say something on the tabletop exercise. I've been cyber attack and I've been through that shooting. Something keep in line with a mass shooting or something of that nature. Dallas and I were sitting there and we were watching them go through these surgical tables to get equipment, to get cables and things of that nature. And or they were going to send these patients to another location for CT to go down. He looks at me and goes, CT just went down. And then we're looking and said, man, you're getting this stuff out like candy. Your inventory is
Actually not inventory that doesn't exist.
So but you're able to check reality into their tabletop exercise and say, yeah, they got 20 of these things. You've already given out 30. Really give them a better perspective of what's going on. And then the IT one for cybersecurity is interesting on that because I've sat on a number of those and there's this perception of what will happen if we take this off. And Stryker was a prime example of a real issue where we're looking how many assets were actually on the network. We were able to identify that. And then what does it mean to shut that Wi-Fi or that IP off? What's that downstream of that? On the tabletop, oh, we're just going to lose this. But do they have downtime procedures? Are they aware we're about to do this? So there's a lot of value that came up from that real-time experience that all the other tabletops, everybody just had an assumption. But the reality with us sitting at the table was, you shut that thing down. So it's not.
And there's a lot of parallels between everything you guys have done, great, and mass casualty. How does your shop respond to mass casualty? Where are you getting your equipment from? Where are you deploying to? Does me and George are here? What happens if it happens while nobody's there? Does everybody else's shop know where? All that stuff is applicable to the same thing.
Yeah.
That's why we're here. It's just like you said, it's probably gonna be 2 a.m. We were fortunate on that one. It was at 9 a.m. Thomas coming in, and we sat there and said, you know, that's why we're part of this presentation. It's like, but we're not.
So I think you also hit upon a very good point. We did not talk about what those tabletop exercises should look like or how to do them. If you're not familiar with the tabletop exercise, get somebody who is. Usually incident command or somebody in that group will get this. They've been trained, they've seen it or whatever, but also get the observers, right? Get the biomed in the room for another reason, because they will spot sometimes what's going on with that workflow of like, well, sure, we'll hand it out like, what did you say, like candy?
Yeah.
And they'll spot, well, that system's not going to be up at this point for the following reasons, because there's an upstream issue, right?
Yeah.
So yeah, get the observers in the room too, because the best tabletop exercises are not just done in pure isolation. You need somebody who may not even understand the situation. I use the biomed as an example that would, but you need somebody that's got a kind of an open mind and saying, what am I seeing here? Does this make sense? And to even call a pause and say, are you sure?
What are you being called upon? What are you going to get a phone call about? Monitoring system, pharmacies, whatever. And have those, like, yes, paper copies are great, but even having a dashboard that you would normally be able to look at, and even if an account, say, how many monitors do I have in a loaner status? Or what's my total inventory and what do I have out for service? You know, what do I have to draw on to fulfill this need? So if somebody says the balloon just went up, we just have a train wreck or whatever it is, and we've got 20 people coming in, we need X. Well, this is what we have. So it's a button push as opposed to you guys going, what? Trying to figure out what's going on. So it's a lot of that.
Yeah.
We're in North Carolina, so we have hurricanes, tornadoes.
Yeah,
And when you're talking about partner systems, we also about licensing
Well, see,
ability.
Absolutely.
yeah, think about it, you would hope it'd be awesome, all of us had, a warehouse full of monitors sitting around the hole, right? We don't, you got some monitor stuff, and you may have a stash of defibrillators or stash of dash monitors or something that aren't licensed. Well, those are digitally dark devices when you bring them out, but they're standalone and they're monitoring, they can go into the surge capacity. But now I got to figure out how much point do Do I have consumables? Where they can be plugged in at? How am I gonna get them back when it's over? That's all good.
Mhm.
You know?
And on the preparation, we talked more about the tabletops and the execution and the planning and stuff like this. But as you're talking about these things, and as you're thinking about these things, we mentioned only a few things like doing those critical audits of power. But another one that Dallas just brought up is, what is your plan in any trauma, any incident, or whatever? What available backup equipment do you have, or do you know in your Rolodex? And again, make sure that your technicians, the guy that's on call at 2 a.m. in the morning, may have been around for 15 years, but he doesn't take care of these systems very often anymore, or never did. They need to have that playbook and that understanding of where to find it, right? At least to say, I've got this in case I can't get a hold of anybody else. It's a different scenario usually than when you're on call, where you could wake somebody up and you're like, hey, you know, I've done that.
We need that playbook.
Yeah.
We actually just started talking about some schemes and what to do, but what is it about that? We
Yeah.
realize we don't have that. So
You download all their brains, basically.
I'm
Yeah.
working on it right now. I mean, I actually sent an email to Environmental Health and Safety, or EE now, and said, do you have a standard, state, whatever requirement of the devices that they would request to be available during the mass gathering? Give me that list so that I can go through and start formulating a list of what we could provide back as a live information.
Mhm.
So starting to get that collaboration going, just so we can figure out what they're gonna need and what we can actually provide and how we go with it.
Let's, in the interest of time, let's just hit this, and then we can take a few questions.
These, by the way, you hopefully have attended other sessions. All the slides will be available, and the presentation will be available through TechNation on their website. It's going to take about a week for that. You can reach out to Jeremy and I, or Barb with ECRI if you've not met her, but she's presenting as well. But you can reach out to any of us. We can give you a copy of those slides. We did not for this, unfortunately. We didn't give you a QR code to kind of download it.
I think there
These
is,
links are very helpful, by the way, and I'll give it, again, credit to the guy who generated the AI images, which, yeah. I started looking back at the slides like, yeah. He being our cybersecurity lead for the device safety group, felt like these are probably some of the most important things to kind of bring up in this presentation to build those skill sets and understanding around cybersecurity primarily. But if you notice, for example, these are kind of the government resources. These are the current things in the US, at least, that we follow, and even in Canada mostly follows. They have some other additional requirements. We do have some time for questions, and if you want to connect with us after, scan the QR code. It'll actually give you the ability to just book some time, right? And have that conversation about what you're doing. I'm curious about what you guys are doing. I know Dallas, so I'd probably reach out to him.
I think what's interesting, you have a bunch of cybersecurity, and most of your facilities hopefully have some sort of cybersecurity department within MIS. We're the step children. If they forget all about, or if it's like, oh, if it's a medical device, that's coming from the internet. And there's a lot of disconnect. So we spend a lot, we actually are fortunate enough, Georgia's worked real hard, and we actually have a cybersecurity administrator within company. So something to work towards, but that gives us visibility to what our needs are, that we can work our needs into their processes and be part of that.
That's very true. University of Maryland Medical Systems has done that for the past 3 years. We actually have a IT department within clinical engineering that is a liaison between biomed and the IT.
We can do this one guy.
Yeah.
Cool. Jealous, huh?
Yeah.
Because well, IT and biomedics have always been separate worlds, and since the integration of EMR, run at like 20 miles an hour. But even terminology and responsibilities were all over the place. So having this hybrid of position, biomed IT hybrid now is more important than ever.
It's interesting, you had this up there. I reported this, yeah.
Mhm.
So we have a really good synergy between all of our IS teams and our CD team. And for 5 years, we've been audited by the this. And it's always do now, do next, do later. Engineering is always later. And it was funny because when Stryker had the issue, and then Intuitive had the breach, I turned around to our security team. I said, how about that do later? You know, where does that put us right now? Because we've been really pushing on network segmentation, kind of mitigate a lot of these risks. And our CIO came up to me and said, yeah, I think you might be due now. Because that was a way
You hit upon a very good point. If you're not at the table, or even if you are at the table, make sure that you help people understand what the priorities you believe are for the organization to try and get them elevated. I know it's a struggle. I actually at one organization said to the equipment management, not equipment management, the EQ committee, the EOC, I should say. I said to him, I said, I think we need to create a position for somebody that's designated from either cybersecurity or the CIO's office. And they said, well, wait a second. And it took a couple meetings to convince them that this was an important element that they needed to consider as far as the environment of care, right? They being IT. It was a good IT organization. Later, we switched over. We started reporting to IT, right? Our clinical engineering department. But the point is make sure that you're all sitting at the table and you weigh in on those priorities, because yeah, things like that happen, and you say, well, wait a second, we could have done something, but we needed institutional support to do it.
Yeah, and it's
they're pushing patches to 1,500 laptops and Windows 11 on. And you're like, we're going to push it to all the medical devices. No, stop.
Yeah.
Quit what you're doing.
So, and
having that conversation, meeting at the table, and helping them to understand there is a difference. We need their support. All that's great, but at the same time, we're not the same.
yeah, and it's good to, like we're talking about, being at the table for what's already in the door, right? But you also need to be at the table and pushing these concerns for future purchases and yeah.
The earliest time to catch it is when the device, before it comes into the door.
You have templates, because one of the things we're looking at is building our risk position and our process.
Yeah.
Do you have templates for things like this, so you gotta look at and?
Not that I'm aware of on incident response specifically for cybersecurity, but I do believe, I'll look, let me get your contact information, but I do believe we might have some resources under our cybersecurity offerings specifically about this and HTM related topics.
Yeah,
right?
HTM, yeah, both. I'm interested. We're trying to figure out how we engage in our policies, our processes under the overall umbrella, so that we know our role when everybody else is trying to figure out their role, and we're not disrupting that workflow. That mass casualty that we had 7 traumas come in, they called mass casualty. It was referred real quickly because they realized it wasn't mass casualty, it just happened to be multiple accidents. But if I wasn't there, he was off that day, but if I wasn't there, who would have known what to do? At that point, we got to start building these things out, and to your point, having that paper.
Yeah. So we know we're past time. We're happy to hang out and discuss, but you're not being rude if you
Yeah,
get up.
get to the next, I think it's the Expo Hall. One thing I will leave with you is we also just published our top 10, and 2 of those happen to be about cybersecurity related risks and digital darkness. One of them happens to be digital darkness. Good, how are you doing? Yeah, I see everyone. Yeah. Good.
Absolutely. Thanks for being here.